First, if you look at any of the anti-inflammatories, you'll find indications. One, painkiller, anti-inflammatory. The contraindications, complications, and so on are the whole list. So this is not abnormal at all. And yes, comparing total knee replacement to unicompartmental is not fair. I agree with you, but you have to know that 30% of the patient indicated for 30% of the patient indicated for total knee replacement are indications for unicompartmental replacement or partial knee replacement. Now I will start by saying that, of course, nobody would say anything about this X-ray except it's for total knee replacement because it's a total destruction of the joint. But what if there is a medial joint destruction only? The lateral side is good. So we have other options. So these we can compare, uni with high tibial osteotomy. To know about Oxford knee, it's been through phases or generations, first generation, second and third. So it's been there for about 40 years, people working with the uni with very good results. Partial knee replacement is all about patient selection, like Dr. Muhammad said. That's true. Patient selection is the most important point. And that's why there is the Cousin criteria who indicated that at the beginning it was 10 to 15 degrees varus, flexion deformity less than 5, the range of movement more than 90, with minimal rest pain, but the age must be more than 60 with low demand patients and the body weight is more than 80. But the extended indication after that came out as you can do it at before the age of 60 with active lifestyle and obese with moderate osteoarthritis of the patellofemoral but without anterior knee pain. The classic indication is one is the anteromedial osteoarthritis. That means that the ACL should be intact, which would lead to medial osteoarthritis, anteromedial, not the full medial compartment. Second is the SPONC or SONC, which is avascular necrosis and bone marrow edema of the medial femoral condyle, and the rest of the knee is pristine. But there are some contraindications, of course, like severe patellofemoral osteoarthritis, lateral compartment osteoarthritis, torn ACL, of course, chondrocalcinosis, inflammatory arthritis, varus more than 15 degrees with fixed deformity, because the correctable varus is a very important point. If the varus is not correctable, then you don't do it. So, 55 years Egyptian female, with medial compartment arthritis, her BMI is 29 and varus deformity, like this picture there. So there are three options and some patients are in the gray zone. This patient, you can do osteotomy, you can do uni, you can do total knee replacement. That's why the selection depends not only on the patient, but for the surgeon expectation as well. So there are good options. Everyone has its own magnet. Each has his own fan, like football. So the same surgery does not fit for all patients and not for all surgeons as well. But if you look here, oops. If we look here, so some surgeons would be with total knee replacement, like Dr. Tariq. Some people are fans of high tibial osteotomy, like Dr. Akram. Or some people would be with unicompartmental for the same patient in this gray zone, which is between the high tibial osteotomy and total knee replacement. But there are clear indication, of course, for the total knee. There are clear indications for uni and clear indications for high tibial osteotomy. So all the talk is about this gray area in the middle here. So this gray area is like a 55 to 65 years old patient, moderately active, mildly obese, mild varus deformity and correctable, no joint instability, good range of movement, and this patient is the patient in the gray zone. So uni is ideal. Is it ideal for Egyptians? Well, it's a treasure, really. Why? Because most Egyptian people have constitutional varus deformity. Most of them had ethnic or religious habits that need squatting. They stand more than 12 hours a day, which causes medial joint failure. And who doesn't see daily in his clinic 1 or 2 patients with root tear? And this root tear is usually 2 to 3 months old because the patient doesn't come directly, which is followed by spunk on the medial side, and within a year the patient is, his medial compartment is bone on bone. So the medial compartment failure with bone on bone, this is our patient. So this group of people usually have mild correctable varus, which has been there for a year or less. Would you do a total knee replacement for this patient? Well, for this uni is considered as a forgotten treasure, really. I thank Dr. Ayman Abeid because he helped me with some pictures and videos for my talk. So this is 62 years old, Egyptian female with medial compartment osteoarthritis, intact ACL. So uni is done, and that's her picture in 2 weeks. Does high tibial osteotomy would do that in 2 weeks? Does total knee replacement would do that in 2 weeks? Well, I don't think so. Who said yes? خلاص طارق said yes, it's a yes. So the case 2, again, 56 years old Egyptian male with spunk on the medial side and intact lateral compartment. Would you do a total knee for a picture that like that one on the upper side? Would you do a high tibial osteotomy? And the lateral side is pristine, is like the cartilage is new. Would you do a total knee replacement or would you do a resurfacing? And this is the patient 4 weeks post-operatively. Last patient is 66 years old with this flexion of his knee. I bet you if a total knee would do that. Not you, Tariq. So, you have easy, quick surgery, minimal blood loss, and low rate of post-operative complication, early post-operative mobility and return to work, less pain and hospital stay, possible to squat, possible to walk on uneven ground, and it's cost effective. ممكن 30 ثانية? I finished. Possible to walk on uneven ground, and 90% longevity in 20 years follow-up. The problem is that it's not cost-effective when you compare it to upper tibial osteotomy. So uni is a good option with marvelous results in selected Egyptians. Thank you.